Our final speaker is Dr. Steve Shafer, who's professor of anesthesiology, perioperative, and pain medicine at Stanford University. He's a recognized expert on anesthetic drug clinical pharmacology, has established many of the concepts we use today. He's received the Lifetime Achievement Award from the International Society of Anesthetic Pharmacology. He served as editor-in-chief for Anesthesia and Analgesia from 2005 to 2016. And in 2015, he gave the ASA John Severinghaus lecture on translational science, choosing the topic of disruptive technology in anesthesiology. And he continues that theme today, speaking on the future of artificial intelligence and its impact on anesthesiology.
All right, thank you very much. It's a pleasure to be here. I want to first start by thanking Ron for the invitation and the IARS for the opportunity to speak with you today. I also want to thank the prior speakers. In putting this talk together, I had this hope that there were certain things that would be covered before I got to my presentation. And thanks, everybody, because you did exactly that. So I don't have to review a lot of this. In reviewing the future of artificial intelligence and its impact on our specialty. So conflict of interest disclosures. My primary conflict of interest is Ron's my boss. So when Ron says, can you give a presentation? The answer is yes. And I thought I would just open by a demonstration of how artificial intelligence will be arriving in your operating rooms almost immediately. Okay, Google. My phone's answering. Okay, Google, raise the OR table.
The operating room table is rising. Tell me when to stop.
Okay, Google, stop.
Okay, stopped.
Okay, Google, raise it a little more.
Raising the table another inch.
Now, there are different companies. Google is really doing amazing stuff, but they have, hot on their heels. For example, we have Alexa. Alexa, raise the OR table.
Thank you for your order. Would you like your new table shipped with Amazon Prime?
Alexa, I want a higher operating table.
Yes, we have a more expensive operating room table. Changing your order now. Would you like one-day shipping?
Alexa, please increase the height of the table.
A second table has been added to your order.
Apple's in this area too. Siri, raise the OR table.
The water table is the groundwater within 100 feet of the surface.
Siri, the operating room table. Raise the operating room table.
An operating table is used during surgery to adjust patient height and position.
Siri, are you listening?
Yes, I'm here.
Siri, please, I want you to raise the table.
That is very kind. I want you to.
Siri, just raise the damn table.
Raise your own damn table.
So, what is AI? How will it affect clinical decision making? Will it replace anesthesiologists and will it reduce errors? So let's first talk about what it is. And I thank Dr. Houle for a wonderful introduction to it. In Wikipedia, the source for all knowledge, it defines AI basically as being intelligent agents. And basically the point is it perceives the environment, it pays attention to what's going on, and it takes actions to maximize the chance of achieving a goal. Colloquially, artificial intelligence is things that mimic cognitive function, and the emphasis really is on learning and problem solving. And Wikipedia goes on to classify things or to identify several areas which are commonly thought to be in the province of artificial intelligence, understanding human speech, competing at the highest level in strategic games, autonomously operating cars, intelligent routing and delivery networks, and military simulations. And of these 5 things they identify, I'm going to address, I'm not going to talk about autonomously operating cars, and I won't do any military simulations, but these others translate pretty directly into things that we will see in anesthesia. This is to be sure you're awake. I'm going to start with speech. And Google Translate is here. How many of you use Google Translate regularly? I should just sit down. Google Translate is nothing short of amazing. It represents an actualization of neural networks, something that could not be accomplished without it. I use it almost every day in my practice. At Stanford, I cannot use it. And probably at any place, I can't use it to get informed consent. That has to be done by a human translator. The problem, at least at Stanford, with our human translators or these phone systems that we use is that the people frequently don't speak English. And so they're great in Russian or Moldavian or whatever, but the English part of it falls apart. So with Google Translate, it wouldn't be uncommon for me to say, Mrs. Jones, your surgery today should take about 4 hours. I will first give you oxygen to breathe, then propofol. You will soon go to sleep. I will also give you pain medication so you feel comfortable on awakening. Now, this involves 3 independent neural networks. The first one is the English speech to English text. My own experience at this point in time is that it's essentially perfect. It virtually never makes an error in this. This is a 7-layer neural network. The next is the English text to the French text. That has been an independent project of Google, and they threw out essentially all of their semantic parsing of language and just put in neural networks trained by entering millions of simultaneous translations of documents in the 2 languages that are being translated between. And finally, the French text to the French voice. Rendering a natural-sounding voice is not easy, and the voices from these things are quite amazing. That's also done with neural networks. So here is the result. This actually, I did this on the plane coming up here. This is a real translation right here. Let's see if we can get it. It's supposed to play, but I got to change my pointer here to something else. Arrow options. Maybe this will work.
Madame Jones, votre opération aujourd'hui devrait prendre environ 4 heures. Je vais d'abord vous donner de l'oxygène à respirer, puis du propofol. Vous allez bientôt aller dormir. Je vais également vous donner des médicaments contre la douleur afin que vous vous sentiez à l'aise au réveil.
How many of you speak French? How many of the francophones understood that perfectly easily? Right? It's actually remarkably natural language coming out of this system. This is done behind the hood with something called TensorFlow. TensorFlow is a language developed by DeepMind. It's the language that underlies Keras, or at least it's probably the most common Keras add-in now. Keras is a top end for TensorFlow. And an article at MIT Technology Review talked about Google stakes its future on a piece of software. This entire almost $1 trillion company, Google, is wrapping their whole operation around neural networks using TensorFlow. Google is not alone in its focus on neural networks. These, at various points in time, are the top 5 market cap companies in the United States, accounting for some huge fraction of the actual value of all stocks. And all 5 of them are heavily invested in the application of neural networks. So what are they good at? Well, at games of strategy, they are unbeatable. This is an article from Nature 2 years ago talking about AlphaZero. AlphaZero was developed by DeepMind, a division of Google in England. And AlphaZero is a computer system that they taught to learn a game from scratch. No strategic knowledge was put into it. The program does know how to play the game because it plays itself. And it starts off knowing nothing and just playing itself and seeing who wins and who loses. And over time, it starts to get better and better at it. Okay, so they applied this to the game of Go. AlphaMind had previously developed something called AlphaGo. DeepMind had developed AlphaGo. And AlphaGo defeated the top Go players. Defeating the top chess players at Go would not be a big deal. AlphaGo defeated the top Go players in the world in a series of games. It wasn't overwhelming, but it beat them, and people said Go would be very hard to computerize because the number of board combinations in Go is 10 to the 179th, I think. That's a big number. The number of atoms in the visible universe is a measly 10 to the 80th, 82, something like that. So it vastly exceeds the number of atoms in the visible universe, just the Go board in front of you. So they said it can't be computerized. But AlphaGo, with neural network-based training, beat the Go champions. They then came out with Alpha Master, which was a Go program which successively beat all 60 top-ranked Go players in the world. And then they developed AlphaZero. And AlphaZero just plays Go against itself and learns and learns and learns. And this shows here in this graph how AlphaGo has, over 40 days of training, has become superhuman. And this was 2 years ago. Presumably now it has, hundreds and hundreds of days of training, and cannot be beaten by human players. They've applied the same thing to chess, and now the best chess players are the chess programs that have taught themselves from AlphaMind and various chess things. So games of strategy with neural networks can't be beat. They're superhuman. How does this apply to medicine, though? And we'll get to that in just a little bit. But we talked about intelligent routing, and I want to give an example of intelligent routing adapted from my Severing lecture, because I think this is an area where we will see it coming into medicine. Here's where I lived in San Francisco, and here's where I work at Stanford Medical Center. And let's say one morning I woke up and just, it'd been a really rough night, and I forgot how to get there. So I might type my address into Google Maps, Google Navigation. That, of course, would be sent rather quickly to the data center. These data centers are huge. These data centers take so much power. They're often located near hydroelectric dams, and we're talking about we're talking about hundreds of millions of processors in these data centers. Phenomenal capability. So what happens is as I start to drive, my cell phone, which has been exiled over there, is in communication all the way down, and the data center is maintaining a map of every road in the world based upon cell phones that are communicating with it, and it navigates me to Stanford, and if there's a problem on the freeway, it will get me off the freeway and route me around the problem. And I suspect all of you have experienced that firsthand. Well, I think this applies very quickly to the perioperative setting, the notion of intelligent perioperative routing. So a patient comes in, and there is a diagnosis, and the notion is that this diagnosis is transmitted to the data center to start the process of routing, just like my talking to Google and sending the Google Maps the request starts the process. The data center gathers the data and says, okay, I understand the diagnosis. I've learned something about the patient from the query to the medical records. The data center then initiates the drive. It checks in with the clinic, it checks in with the laboratory, and it contacts the patient. And in reaching out to the patient, just like Google, just like my phone tracks my progress as I'm driving, it directs the patient to the medical center, it directs the patient to the laboratories. Now, part of reducing errors is it looks at the results that come back, the patient things, and it goes through the checklist. What was missed? Because one of the problems is we miss stuff, as Warren talked about in his presentation. So it checks it. Patient comes into the hospital, this being Stanford. Again, more checklists. What are we not going to, what are we missing that needs to be catch? He then directs the patient to the operating room, follows the patient to recovery, and it eventually directs the patient back home safely. And the idea is that it is following my progress in just the same way that my phone literally follows my progress as I drive from San Francisco down to Stanford. That's not that hard to envision happening in the future. Well, will it affect decision-making? A couple years ago, I would have said yes, and that was based in part on a multi-billion-dollar gamble made by IBM in the creation of a system called Watson. And here, rather famously, Watson's defeating, at the time, the two best human Jeopardy players. Not just anybody, the two best people in the history of Jeopardy until the current contestant. And by the time it was done, Watson had more than their other two players' combined scores. It wiped them out. And the reason that IBM pursued this is they said, we're going to take Watson and we're going to do something amazing with it. The same general skill and question solving and stuff that allowed Watson to excel at Jeopardy, we're going to throw all of this into Watson for Medicine. And we're going to put in journal articles and guidelines and databases. And the idea is we're going to come up with recommendations for the individual patient. And this was announced in about 2013 with great fanfare. IBM Watson for Oncology. Watson provides clinicians with evidence-based treatment options based on expert training from Memorial Sloan Kettering physicians. Memorial Sloan Kettering put out press announcements to this effect. Multi-billion-dollar experiment in the application of AI to clinical decision-making. As of last night, if you look for IBM Watson healthcare outcomes, there are exactly 0 publications showing that it works. And last year, a little secret came out. IBM Watson supercomputer recommended unsafe and incorrect cancer treatments, internal documents show. How can the computer AI be the best at Go player in the world and fail so badly at this? And the answer, I think, is obvious to all of you. So I won't even say it. But actually, I guess I should say it. But Go is a limited domain, very precise in that domain. And the computer can develop utter mastery of it. Medicine is messy. The data are conflicting. They are wrong. They are influenced by wild stuff that you've got to think about. Maybe this patient, there's something going on in their personal life, which is why they have pain today that wasn't picked up in the pain thing, because they're going through a difficult thing with one of their kids who they've discovered has gotten pregnant and run off and gotten a tattoo and and gotten married. And that's the kid that comes back and the mother says, yes, I understand the marriage, but tattoos last forever. But there's medicine is messy, and computers don't deal with messiness well. IBM Watson Health still exists. And there's even a thing here for clinicians. If you click on this thing for clinicians, here's what you see. For oncologists, yes, there's still oncology. It identifies inconsistencies in care. Okay, I can kind of get that. A neural network, it knows what care looks like. It looks for inconsistencies. Very different from coming up with optimum treatment recommendations. That just went away after billions of dollars in what I would say is an unsuccessful experiment. So, well, these machines replace anesthesiologists. And I don't know why. I think anesthesiologists have a bizarre fear of being replaced by the machine. The notion is that this is going to walk into the patient's room and say, hi, I'm Dr. Cyborg, and I have some questions for you. Anybody in your family ever have trouble with anesthesia? So the issue here is that human dexterity is unbelievable, and machine dexterity is terrible. We can have a conversation about robots here, but there is no general purpose dexterity. Look at this little baby here. And we have an infant which is going to be fed by a very young child. And look at the dexterity of this very young child and the care in feeding the baby, how cautious it is. Now, people have tried to do this to feed patients. And, or similarly, this is the U.S. women's soccer team in the 2015 finals against Taiwan. This is what general dexterity looks like. And these are computer soccer players. And this is also a world championship in 2015. Look at what human dexterity looks like. Now, this one that just fell down here, it's a little freaky. It's going to get itself up. And you said, wow, that's it. But the goalie just fell over too, and nobody's going to think twice when the goalie gets up. Computer dexterity is terrible. They're unbelievably clumsy. I will say, though, it seems that bad sportsmanship is well understood. Now, this video is the winner of the 2015 General Purpose Dexterity. What does general purpose dexterity mean? So Dr. Hemmerling showed us some robots. Ask that robot to make a turkey sandwich. Ask the robot to cross the street. and buy a turkey sandwich. And the robot's going to struggle. That's what general purpose dexterity looks like. That's what you have to have if you are a clinician in the operating room. So it's trying to fold a towel. It's sped up 3 times, because if I didn't speed it up, it would be like watching paint dry. Now, Dr. Orlando Hung. Orlando, are you in the room by chance? From Dalhousie, he's one of our colleagues here from Canada. And this is Dr. Hung, who is preparing a case for anesthesia. This is what general purpose dexterity looks like. And robots, I don't think will ever have this kind of dexterity to get everything ready, get everything prepared. That's what human dexterity is. Machines, I predict, will never have it, because that requires biology. The robot is nearly done, as is Orlando. The final fold, it's done, except it got it wrong. You could fix that instantly. The robot doesn't have a clue. And meanwhile, Orlando's ready to give anesthesia here. So will AI reduce errors? Because this is one of the real hopes. Maybe, but there's this whole issue of safety versus complexity, and that was talked about in the prior presentations, and thank you for that. We have an incredible demonstration. It's not an AI demonstration per se, but a demonstration of safety versus complexity is the Boeing 737 MAX. And as you're all aware, there's a problem with this plane. And the problem with this plane is there's this whole, first off, the engines are located too far forward. Because of the forward positioning of the engines, the plane tends to push itself up when you give full power. So the FAA said you've got to put an automatic system to push the nose back down. So they came up with an angle of attack sensor right here. And if the nose is too high, it pushes it down. But Boeing did not adequately think through what happens if the angle attack sensor fails. In trying to go for safety, they added complexity. Their training systems did not account for it, and 2 planes went down because of a failure from the added complexity of this maneuvering system. Neural networks fundamentally are many-to-many mappings. Think about trying to bring EPIC and tie EPIC to every patient and tie it to everything going on in the operating room. It is a profound many-to-many mapping, as opposed to the sort of simple mappings where you're just going to take, okay, we just have one input and we're going to go look at a couple outputs, or one output, we're going to look at a couple inputs, we're going to look at one output. These many-to-many mappings are very complex. How complex? I decided when I moved to Menlo Park a couple years ago, I was going to put in some sensors in my own condo. This is a 1,500 square foot condo, just a little place that we have near Stanford. So I started putting some sensors in, and then it got a little more sensors and some 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 more sensors. And by the time I was done with it, we had over 200 devices talking to each other in the condo. The fun part is I can walk around and I can just talk to the house, and things happen. And I can talk to the thermostats, I can talk to the lights, I can talk to the garage door. I say open sesame and the garage door opens. These kinds of things are fun. Just my own little place takes about an hour of maintenance, maybe 2 hours of maintenance every week. It's much easier just to turn the lights on. Think about trying to bring this kind of complexity into the hospital, and I could go on for hours about this subject, but the point is we would like to focus on the idea that AI will catch stupid mistakes, and it will optimize patient care. But I'll tell you right now, just as Boeing discovered with the 737 MAX, which is not AI systems are intrinsically more complex, AI will introduce errors, new errors, that humans would never make. And how do we catch these? Because we can't really debug these. So the future of AI, how will we get there? We will evolve there. Slowly but surely we will adapt things. As far as I'm concerned, if the most that AI ever gets to the operating room is Google Translate, that's a huge win, because Google Translate is amazing and I use it every day in my practice. And that represents pure AI, and it works. It's a demonstration of the possibilities. If that's as good as it gets, that's great. But I think it's going to go much further than that. The other thing, though, I have to just say about AI, there's more to anesthesia than the eye. Thank you very much.